Hi everybody, it's lovely to see you all today on International Women's Health Hub Day. Interesting, International Women's Health Day. International Women's Health Day even. So can I just check, just with a raise of hands, how many are actually in the group who are actually involved with Women's Health Hubs, directly or indirectly? Maybe you're working as a GP. So welcome, Leslie. Lovely to see you here. So I'm going to be kind of speaking to the knowledgeable here. So if there's any other things that you want to add to what I'm saying, because I'm just giving a very quick overview of what Women's Health Hubs are about, then please do add into the chat your thoughts and reflections. So next slide, please, Helen. So women's health hubs are have really brought a focus on women's health into the work that ICBs are doing in England, and I guess they are equivalents in Wales as well, Nadia, by the sounds of it. And I think there's a few things for those of us who perhaps don't know that much about how they work that are really important to understand. So the first one is that they are about building a network that is in the community, so bringing care and support closer to people born female, rather than them being a physical place in most areas. They're all about a partnership, and that partnership spreads beyond the NHS into local authority, into the voluntary sector and third sector. And they want to be partnerships that listen to what matters to women and girls and drive improvement and integration. And their focus is on well-being, on improving outcomes, on equality and providing addressing inequalities, and also improving experience of care. And when we look at that in the context of group clinics, we can very quickly see why group clinics could really fit well with what women's health hubs are seeking to do, because group clinics are all about taking a holistic approach to how we support people through their journeys that may be medical, or maybe a life transition like menopause, where they are living with symptoms that we can help improve through a treatment like HRT. But also the evidence suggests from the research that compared to one-to-one appointments, albeit in chronic conditions like diabetes, where lifestyle change is important, group clinics actually improve outcomes. So that's something to bear in mind. There's also quite good evidence.
Oh, I'm fine. Just the webinar. That's okay. Yeah.
Yes, I saw that email from Claire.
Ravi, Prima, rather. You no, not. Thank you. Lovely. Sorry to shout. Thank you. So there's also some really good evidence to show that group clinics have a positive impact on health inequalities. And perhaps one of the reasons for this is that something really magical happens when people come together in a group, particularly people who may feel quite isolated and who may not actually have a very strong sort of social network around them. So being part of a group for their medical care really seems to help to motivate and boost the confidence of people who perhaps come from a more chaotic background. And the evidence is also quite strong that group clinics improve experience of care. So if we look at those two things, we can see that there's a very close match in relation to women's health hubs and group clinics. Group clinics also drive improvement. So you saw that diabetes results board. So where you've got a condition where there are quite a lot of metrics that need to be managed, where we need to be monitoring people for things like symptom scores, the group clinic results board helps to nudge us to make sure that we actually monitor these things properly and align what we're doing with guidelines and protocols. So for instance, there's evidence that group clinics increase QOF compliance, and that is that is a marker for quality. There's also evidence that they actually help support an MDT approach. And this is all research evidence. This is not me making this up. This is what has been shown in published research. So there's something about how group clinics support integration, because you can have several clinicians potentially working in a group clinic with the group of patients. And that helps the clinicians to learn from each other and complement each other as well. And then the third way that group clinics really fit with the Women's Health Hub model is that where we're looking to perhaps build clinicians with a specialist interest who can work and improve menopause out in the community, linked in and supported to secondary care experts in that field, having a group clinic model can really help to build that networking potential, because the specialist can potentially bob into group clinics and see groups of patients in the community via group clinics. And also it helps us to build a really robust integrated system that is a community network. There's also good evidence to show that patients often stay connected after meeting in group clinics, and also set up their own kind of peer support groups and that kind of thing. So we're actually building social capital through the group clinic model. Next slide, please. So I just wanted to also share with you that we have done some work to independently evaluate menopause group clinics. And what we found in that evaluation, which was qualitative, is that exactly or very similar things to what I've just been talking about. So group clinics build community. They also create a sense of fleeting support and a sense of being validated by relatable others, so their peers who are going through the same journey. And we find within menopause that that is particularly important, and often that makes the difference between somebody saying, do you know what, I think I'm going to just try and cope with this now that I've met some other people and realized I'm not alone with this. That's almost enough to give me the courage to keep going and see how I get on. And I'll come back if I think I want to get HRT prescribed for me. And then it builds their confidence and knowledge, and they get lots of ideas from peers as well as the clinician. So you've got all the wisdom in the room, not just the clinician with as a source of wisdom. You've got all the other people in the room as well. And all of this means that people gain the ability to take control of their menopause journey. So it's a really positive thing. And if we think about the way that we support women at lots of other transitions in their lives, like when they have children, you know, we all gather in groups, and it's a pity really that we don't do that more during the menopause. You know, people tend to sort of go into themselves and maybe not talk about it so much. That is changing, but this is the group clinic model provides a great way of building that community around women. Next slide, please. So this gives you a really strong rationale for women's health hubs to embed group clinics in their work. And in fact, the national specification for women's health hubs does specifically mention group clinics or group consultations, as some of you will know. So it's going to help people, and not just in menopause, make sense of their journey and their experiences. They're going to gain knowledge and a sense of control. It's actually going to increase the trust in the clinicians that are working with women. That's also a known positive impact of group clinics compared to one-to-one appointments, and create community amongst relatable others. As we found from the menopause menopause group clinic evaluation, the group clinic model also feminizes service delivery and builds in equality. so that we change the power dynamic and shift responsibility to the person, but give them that support to help them to make change. And it also is scalable because it's also highly efficient. And I'm sure that Ellie will be telling us a little bit about that. So very quickly, I'm just going to highlight for you some of the services that are in the specification for women's health hubs and the ones that would be best suited to group clinics. So we can have the next slide for that, please. So what you're looking at is appointments where you're not going to have to do an intimate physical examination. So obviously menopause fits in really well there. But often these are some of the other services that are in the Women's Health Hub spec as well, where you could potentially look at group clinic management. So osteoporosis, anything which is of a kind of counselling type service, breastfeeding support, discussions about strategies to help with incontinence and pelvic organ relapse, fertility services. These are all examples. Next slide, please. So likewise, I've kind of done a little bit of a traffic light on these services. So these are all mentioned in the Becky, would you mind muting yourself? Thank you. In the specification. So you can see the ones at the top, they could work really, really well is in a group clinic model for at least part of the pathway. Likewise, so I've put cervical screening in as an amber. That's a really interesting one. Some of you will be working in areas where cervical screening is very low in terms of uptake. And we are looking at some group clinic models around shared decision making before the person goes for their cervical screen. So to engage people and help them to understand the risks. So that's why I've got that in the amber one. Like that would also fit with HIV screening as well and other STIs. And then obviously there's some things which definitely involve physical sort of work, and that obviously would not fit for a group clinic. Although anything that is about gaining consent or explaining how something works, that kind of thing, that could be done in a group setting. Okay, next slide. And then the specification also talks about areas where you would look at integrated and MDT working. And there's some examples there from the specification where group clinics could fit very well. So let's move on and hear from Ellie. So Ellie's focus today is telling you and sharing with you her story around menopause group clinics in South Molton in Devon. So Ellie, over to you.
Thank you very much, and hello everybody. So I thought I'd start with saying where I am in Devon. We're just coming up from the M5 up to North Devon, and I'm at a surgery where we have 12,500 patients, and we set up some video group clinics, so you can see where we are. And I'm a GP. I'm not a menopause specialist, but obviously I identify as female, and so that's kind of where I'm coming from. I haven't got control of the slide, so if you wouldn't mind moving me on, thank you. So you've heard a little bit about the process of setting up clinics and kind of how that works. I came into this as I was doing the New to Practice Fellowship, and there was an opportunity to get the training by these guys at the ELC. So we took up that opportunity and had that training, and then went through this process where we did some planning, set up the clinics, did a trial clinic, and then had real clinics going on. And we're having ongoing clinics approximately every 3 weeks, which we offer at different times of the day. So depending on what people want. Obviously, this cohort of people are generally in the sort of 45 to 55 age group. They're often quite busy working, so we've had some good uptake at different times of the day, but particularly good in our enhanced access sessions, which we do offer a couple of days a week. So yeah, so we do that, and then we carry on getting ongoing feedback from patients to try and improve our quality of the service that we're providing. Obviously, they mentioned about who's in it. We initially started with just one facilitator, and then myself as the clinician. The facilitator was also the clinic coordinator, sorry, not administrator, I've got the terminology wrong. We also had some good support from our practice manager to get the team to set these things up. Since then, we've expanded our team, so we've got more facilitators and more clinicians doing both menopause topics and other topics. So we've increased to add in cholesterol management and things like that from last September. Okay, thank you. Next slide. So how it works for us is that we only look at ladies who are looking for new information about, they're newly asking us about menopause, or they're newly asking us about HRT. We're not dealing with follow-ups at this time in our clinics. We have a link on our website which says, oh, here's some information about it. And then we say, our facilitator or clinic coordinator contacts these individuals and says, right, would you like to come and join our video group clinic? And if they do, which after she talks it through and explains it all, we then sort of invite them to that. We use Accurix via our clinical system, which is system 1, which allows us to send a questionnaire, which is what a Florey is for those who aren't familiar with that. So we basically do some sort of initial things in that questionnaire. So we're asking about what they'd like to get out of the clinic, and then we also do some sort of safety questions, regarding things like family history of any cancers, etc. Ask them to do their blood pressure, make sure their smear's up to date, those sorts of things as part of that. We then have the clinic. The patients will come in, and usually is about an hour to an hour and a half for them, because we're doing ours through the video link at the moment. So obviously the safety checks, making sure they're okay. Where are they? Those sorts of things to start with, and then myself or one of my colleagues would join in. We've just sort of basically we get them in, and we have had up to 10 patients in our evening clinics, which is okay, but it is a little bit tight if you've got a very chatty group with regards to that. For me, it takes about 5 minutes to do the prep, because most of the information is collected by our administrator in advance. So I just have a quick read through that, check about the questions, the common questions that are usually asked, as you can expect. And then it just is a little bit of administration afterwards for myself as a clinician, usually because I'm doing prescriptions and just writing some notes about it at that point. So obviously it depends on how many people go for HRT, and we use Microsoft Teams, as that's a secure thing, as advised, safe for patients and confidential. All right, that's great. Next slide, please. So as I mentioned before, we're now using it using a PCN pharmacist, and she is doing statin educations, and she's been doing that since September last year, and running that every 3 weeks. And we're hoping to get our using it for other areas as well. And the only reason we haven't done that as yet is just because of the staffing within our nursing team, people on maternity leave and so on and so forth. So the timing's not quite right with that at this stage, but really think it's a very useful way to impart the information. The other thing about it is that it standardizes the information that's being given, and giving a little bit more time. Next one, please. Yeah, so just a bit of clinician feedback, really. So we have 10-minute appointments as standard in our surgery, which isn't ideal. Everybody would want to have longer than that. I was finding that I was, as a female, getting quite a lot of women's health queries, and sometimes people would come in quite aggressive, just wanting to, or very tearful, and sometimes that was, not easy to manage within a short time scale. So this way we end up allowing patients to have a bit more space. they're able to share their experiences, can have a few tears if they want to, but they're sharing that with the other ladies who also got, those experiences. And so that's been really helpful to sort of be able to not have repeated conversations, or to be running very late for those individuals. Yes, and as they said before, so we do an initial sort of education bit. Patients will sometimes share their experiences as they go along. Sometimes they share it closer to the end. Each patient gets a sort of opportunity to speak to the clinician one-to-one, and then they share their sort of questions, and often, because they're similar questions, it means that you're not saying the same thing over and over. Okay, next slide, please. So this is just a few testimonials from some of our patients, particularly from the menopause clinics. They often find it really helpful, like we've said, about the sharing of the experiences. That's the key bit about this, compared to the one-to-one, in doing it in a group and being able to sort of bounce off each other and realize that they're not alone. Some people are more chatty than others. Even the ones who haven't chatted that much have back to say, I felt I could share if I wanted to, but it was really useful for me to listen to other people about what they were going through, and I wasn't alone was the key thing there. All right. So that's sort of a quick whistle top. So I think I just said questions. Here's just a few things about come to North Devon and see all these beautiful areas that we've got here, and go on from there. I didn't want to spend too long on slides, but I did want to give people an opportunity to ask if they had any questions about how we've set it up, any concerns, problems, those sorts of things, anything they wanted to go for. I'm not sure if the easiest way to do it is by the chat.
Yeah, I'll feed you the questions, Ellie.
Thank
So
you.
I've got a couple of questions. So there's a couple where it's more of a process thing. I've answered the question in the chat, but an interesting question's come up, which it might be interesting for you to reflect on. So do you think that you could do a mix with HRT reviews and new patients in a group clinic? Or would you want to always keep them separate? I know you've been doing them for quite a while now. So, and I think we talked about it when we did our training together. I think I encouraged you to mix them up maybe, but you haven't done that yet. What are your reflections on that? Do you think you would have a separate one, or, how do you think that could work?
So we have thought about that, and I know that obviously we did the training some years back now, it feels. So with regards to that, I think it's for when patients have been on HRT, let's say previously, stopped it and then come back to the clinic as a sort of new patient, they've sometimes shared their experiences and their thoughts on that, and that can be really helpful for some of the ladies to hear the success stories about it. Often there are some concerns, generally due to the media. It's not usually up-to-date information that they're concerned about. So I think it could be useful, but we haven't done it as yet. We do have a fairly robust process for our HRT reviews, which I'm unclear whether it would be time efficient at the moment, and so we at the moment we're keeping it separately.
Do you do those remotely, your HRT reviews at the moment? Yes, yeah, so it's a kind of is it a flurry or something like that?
It is, yeah. So it's effectively a questionnaire, and then a sort of either a telephone appointment or just a text. Oh yeah, thanks for your information. Off you go. Here it is. So here's your prescription. So I think that feels difficult to then put into a group consultation.
You'd almost be creating work for yourself, I suppose. But if you did have to see somebody who, if following the questionnaire you wanted to recall somebody, you could potentially recall them to the group clinic maybe and see them in that if you wanted to, rather than a one-to-one appointment.
Yes, absolutely. And I think obviously there's always adjustments that need to be made down the line to people's prescriptions and so forth, or maybe a prescription might not be the most appropriate outcome for that patient from that clinic. I think some some people would like to come back to have a chat with the same ladies about how they've got on, but at the moment we don't offer that as a follow-up, but just because of the way our systems are set up.
Yeah, so we've got, what does the facilitator do after the clinician leaves? I'll very quickly just answer that. So basically they work with the group to set some goals of what they're going to do to actually move forward. So it might be, you know, I'm going to do a bit more exercise, or I'm going to do, you know, join a Weight Watchers group or that kind of stuff. So it's a kind of like goal setting. And then they close the session and ask for some feedback about the session. So that's what happens usually after the clinician leaves. What one of the other members of the group has asked is, do you find women who cannot have a HRT benefit from the group? So I don't think you do any screening, Ellie, do you, to see if, you know, or you might not know if somebody has got a history of breast cancer. So what would you do in that situation if that has come up?
Yes, absolutely. So if you think about the information that you're trying to impart, it's not about necessarily, oh, here's a prescription for HRT at the end of it. There are obviously other elements of education regarding women's health, menopause, like, you know, lifestyle, such things, obviously CBTs coming into the NICE guidance, and those sorts of elements. So we talk about those bits as well, and depend on how much time we spend on that will depend on what the individuals in the group want. So that's why we send a Florey questionnaire to ask about what sort of things people are wanting out of the session, because if they're all like, I want to know about alternatives to HRT because I want to know about exercise regimes and things like that, then I will target the session more geared towards that. But if they're all about, no, I really want to know about HRT, then I will spend more time on that. So we've had people before who've had breast cancer in remission. We've had people who got strong family histories and so of all types of cancer, and they're concerned about that. So they come and they listen, and we target the clinic according to their wants and needs. And yeah, it's not all about the prescription at the end of it.
Yeah, and of course, like any kind of appointment, you can always follow up with people, can't you? And so if you have a lady who's got a complex history, this is almost like a bit of a triage as well. So you might say, actually, we definitely do need to talk to you one-to-one as well as this appointment if they were interested in HRT, or you can make a referral or whatever. So it's, you know, there's a kind of triage element to this a little bit as well, isn't there?
Absolutely. I think our facilitator, puts these ladies and says, right, and we'll put those in the car park as the terminology, and we'll come back to that. And it also gives you an opportunity to say, oh, your smear is not up to date. Would you like us to book that? And then we send them an appointment for those things. And so there's a lot of other elements that can be done, as well as just imparting the information, potentially arranging a prescription. Obviously, there's taking other information.
Yeah, well. And Victoria has asked about that actually. So she said, do you cover QOF, BP, BMI along the way? Use the green climatic score, which I'm pretty certain you do, if I remember correctly. You do symptom scores in advance, and then and prescribe. So there's several questions about prescribing, Ellie. So tell us, how does that work? So you've gone round and you've established that a number of people want HRT. So how do you do that?
So when they're in there, sort of, obviously we've done all the information, we've had a chat about stuff, and then we go to each person individually and say, how would you like to proceed? And that's a little bit about their goal setting, about what they'd want to do. So depends on the vibe of the clinic and the cohort, the individuals that are there. So some people say, yes, I'd like HRT, and then we will take that opportunity to talk about what type of HRT would be preferable for them, in the form of, patches, tablets, gels, and things like that. And then we will sort of make sure about when their last menstrual period was, and arrange, and then sort of I'll just jot a little note down on a piece of paper next to their name, and then I will check their pharmacy, practically talk to them about the prepayment certificate for HRT prescriptions, and then I will that's what I do in my sort of 15 to 20 minutes after the session, is I then generate a prescription if it's safe to do so. If there are things outstanding, blood pressure checks or we need to identify something that I hadn't previously picked up on in the notes or whatever it might be, I would obviously take that back to the patient and have a text exchange. Usually our facilitator is excellent at identifying those patients who have got missing sort of parameters as well, so she will follow that up for me with a sort of administrative thing. So yeah, so that's what we do. If they're not sure or they want to come back to us at another point, have a think, come back to it, then our process at the moment is that's fine. We just document our consultation. I put some notes on about if they did go for it, what sort of thing that they might, from a, would they have a continuous prescription, or would they have a sequential regime? Put some notes on to remind myself so I don't have to get my brain involved too quickly the next time around. And then they may send a task through, say, I've attended the video group consultation, I would like to go forward for a prescription, and then I would that would come through to me as a task, or through to the other clinicians as a task, and then we would action that if we felt we could do that from the information we have.
Brilliant. So I've got Victoria's asked, do you keep the patients with strong family history or PMHX or breast cancer out of the group clinic? So do you actually screen them out, or do they come along anyway?
No, they're welcome to come. When we've had conversations with them about that, because we're not just talking about HRT, we're talking about other things too. So they're welcome to attend and learn what they can about the other options and alternatives.
And how often do you do these clinics?
We're running them approximately every 3 weeks at the moment. I'm doing one every about 9 weeks because I've got 2 other GPs who are doing it with me. So we just sort of take it in turns at the different times of day. Sorry, go on.
Yeah, it's practice level, isn't it?
Practice level, yeah. I noticed there was somebody from Braunton in the chat, and that they're within our PCN. So, I know that a couple of the practices have been interested in hearing a bit about it. So, I'm always happy to share our learning about it and the practical bits about setting it up.
So Victoria's really focused on this, and she said, would you say this is an educational consultation, or is it a medical consultation? What is it? What does it feel like to you, Ellie?
To me, it's a medical consultation. I think that was quite clear from what we needed from it when we were setting it up as a practice level, because we didn't want to have further appointments created from it. The idea was that we were going to try and be more efficient about the appointments that we were offering for women's health for menopause. So instead of having a 10-minute and then, we can't cover everything, we need another 10-minute, and then we need another 10 minutes, we're now doing it all in one, grouping people together. And although there may be a handful of follow-up queries that may need to be made or adjustments, my belief, and I haven't checked we haven't got data before and after because I didn't take it, I didn't think to, my belief is that it's saving repeat appointments and repeat consultations.
Well, the evidence shows that women usually need 8 appointments with a GP before they get HRT. Sorry,
my dog's just yawning in the background. That wasn't a strange
no problem. So if we know that that's the case in general, your patients are getting 1 appointment and then they get HRT if they want it.
Yeah, I would. I don't. You've got all the data there, but I'm pretty sure we're being a lot more efficient about it. Although they have a longer appointment and allocation, we're fitting people in that way, doing it as a group.
Yeah, so it's a longer appointment for them, but for you, it's quite an efficient use of your time. So Kim from Sussex has asked, what about digital exclusion? What are you finding? I mean, video group clinic for women during with menopause symptoms, what we're hearing sort of nationally that does work really well, and often they quite like joining from home and on video. But Elliot, are you finding there's people who you can't see because of that?
Yeah, so we're asking people where possible to attend a video group clinic for this purpose. But if patients are unable to, and there's no way of sort of helping them with their tech, which obviously we do try to provide support in the appropriate settings, then we offer them a one-to-one as we would have done previously. It's not like we're excluding them from having a consultation about menopause. I think thinking about our statin cohort, if you think about the range of ages you might be identifying in there, and you know, I'm not meaning to be ageist, but some people don't have access or don't have the will or the wants to learn about the IT, then likewise they are offered a one-to-one appointment to discuss the same issue. We had considered bringing it in-house into the sort of not doing it remotely as an option. The limiting factor there is room capacity. We do have a room that has enough space, but at the moment used by our social prescribers, so we haven't got that available at all times to use.
Yeah, so it is important to remember that you can do group clinics face to face as well, but it is often the issue in general practice, isn't it? Space and estate. So video does give you an option to do that. So Simon's asked, are most women happy to share their medical history or family history in front of others?
You'd be quite surprised actually, because you think some people are going to just not be keen on this at all, but they do really open up, and some people are open from the get-go. They really sort of tell everybody everything, intimate details and all, and other people are a little bit more reserved, but towards the end of the session they really start opening up and sharing those experiences. And yeah, so if they sort of seem a bit more reserved, I've obviously got their medical history on my information, so I wouldn't sort of overtly share that in that setting unless the patient brings it themselves. But we sort of generally talk about those problems. But yeah, people are quite open.
It's always a great shock to clinicians when they do their first few group clinics how open people are, I think. So Lizzie's from Starport has said, how do you document? I think you've covered that really mainly, but she said it feels like 15 to 20 minutes of admin to her. How long now that you're really used to it, Ellie, how long does the documenting take you after the group clinic?
It really depends on the number that attend and sort of the things that are discussed. We use we have Ardens through our system one, so I use the menopause template and just tick the boxes, and then a couple of comments. It's our facilitator or clinic administrator also puts some information on, and because for most patients I've got that pre-information, like I say, sorry, that's dog again. Their blood pressure and those sorts of things, most of the information is on there. So if I've got a full clinic of 10, then it probably will take me about 20 minutes for those, because obviously that's 2 minutes per patient, which doesn't seem a lot, but mostly we will end up with somebody cancelling last minute or something like that. So it can be, it can be about 10 minutes, but it just depends on the group on the day.
And Serene has asked, as a GP, does this group session replace a clinical session?
As we could, as in like a whole clinical session? I mean, it will take out of no. So I will do it as part of my day, if that makes sense. So if I'm doing the late surgery, and we would have patients booked in visually between 6 and 8, then that I would allocate all of that time for that. For the I wouldn't have other patients also booked in around that, but we would say probably book out about an hour and a half of other a normal sort of sessional time, and that's usually sufficient to get most of it done. If we're being generous and it's a new clinician learning the ropes, then we might give them a little bit longer.
Yeah, so it's not a full, it's just like part of a session, but then you might see some other patients in one-to-one appointments, but you might just do some admin work or something during the rest of the session, depending on what your priorities were, I guess. We have got loads of questions and they keep coming. So we will share. We've had several people asking for your Florrie template, so hopefully you wouldn't mind sharing that with us afterwards. We'll send it round to everybody. Somebody's asking about contacting you about the cholesterol groups. So maybe Ellie, just pop your email in the chat before you, if you're happy to do that, so they can get in contact with you. And then somebody's asked, is this covered under enhanced services contracts? So the Women's Health Hubs, I think, Abigail, you might be getting a bit confused. The Women's Health Hub is something that's happening at an ICB level, but the job of the Women's Health Hub is to help to improve the quality of women's health in the ICB. So it's kind of like leading that change. And a lot of women's health hubs are looking at introducing and supporting general practice to set up menopause group clinics as part of that initiative, and even looking at how they can use group clinics themselves. So, you know, in general practice, you have to support women through menopause. That's part of what you have to do, and this is a different way of delivering that, you know, in a group clinic model. So it's covered by a GMS contract in effect, and when you do it in extended hours, Ellie, it counts, doesn't it? So if you've got 10 appointments in your group clinic, that counts as 10 extended hours appointments.
Yeah, absolutely. You know, we just put them in as video group clinic appointments, and that adds to our numbers on that.
Yeah, we're continue. So I've got another one, which is a good one for us to pick up, and then I'm going to probably have to use, but bring us to a close. But did you find any reluctancy from patients to join the video group clinic?
So some patients will not do it. They don't want to share, and that's whatever persuasion and however nice your clinic administrator is, you will not get them in. But those people who are a little bit hesitant but have an open mind, they join and they get a great deal of value out of it, as evidenced by the feedback. So you know, some people just won't do it, and if they won't do it, then there's no point in really pushing that. But I think we've had really good success from the patients that do attend.
I think one of the sort of selling points for patients is often that they can get an appointment quite quickly in a video group clinic, where they might have to wait several weeks to see the GP one-to-one. So when we're actually, for those teams who are on our training course, we're actually doing a masterclass on patient recruitment, because it is an issue, and we do need to work quite hard to get our patients to try new things like this. However, once they try it, they generally really like it. So it's almost like, you know, it's going to be good for them. So say to them, give it a go. If you don't like it, then we'll talk again. You know, that kind of strategy works really, really well, because we're doing it in their best interest, and they can't make an informed decision until they actually give it a go. That's the bottom line of it. So yeah, so that's something to think about. And then I'm going to take one more question and then hand back to Helen, and that is the most popular time, Ellie. What's the most popular time slot?
It's evenings, because they've had their work day and they're ready to join then. So the evenings have been really easy to fill, but we want to make sure we offer at all times. And obviously I prefer doing it in my normal working day. But yeah, you get good chat in the evenings. People are quite happy to explore.
Yeah, brilliant. Thank you so much, everybody, for being so good at posting questions. It's been really, really helpful.